Okay, hello everyone. Sorry again. Apologies for these problems we had with the connection. We're trying to figure it out. Now I'm going to share the screen with you. Okay, excellent, fantastic. I'm just asking my colleague Paul if he can send me a confirmation via WhatsApp that you can see me, hear me, and see the presentation as well, please. So, I wanted to start it again. I will start again from the beginning. Sorry for the people that listened to this already. I wanted to thank Asnat and his team for organizing this conference and for inviting us. My name is Davide Lanfranco. I'm a physiotherapist living in London, and together with Stefano, Nicolò, Giandomenico, Valerio, and Paolo, we represent Fisioscience International, that is a branch of Fisioscience Official. We are an association of physiotherapists with the aim of spreading good, evidence-based, high-quality physiotherapy all around the world. So, when Asnat asked us to present a lecture, he told us that the people who are going to attend this lecture were people from different professional backgrounds. There were physiotherapists, biologists, psychologists, some medical doctor, and so on. So, we usually speak to physiotherapy, so it's not easy to find a topic that could be of interest for us all. We decided to speak about the person-centered approach, so the importance of putting our clients, whatever is our profession, at the center of therapy. So this presentation will start with the biomedical model of care. We'll move towards the biopsychosocial model of care, and then we will have a look, a specific look to pain and how pain applies to how the biopsychosocial model of care applies to pain. So if you have any questions, please let me know. Just bear in mind I don't see at the moment the screen, so if I ignore your question, it's not because I want to be rude, but I will answer them all later. So let's start. So before the 17th century, more or less, diseases and illnesses were seen globally, worldwide, across every culture and religion, like a sort of punishment sent by God for people misbehavior. So if I was not behaving well, God was going to punish me, and one of the way to punish us was through illnesses and disease. One of the first person to try to give a more scientific understanding of all of this was René Descartes in the 17th century. René Descartes is a French philosopher that became famous among the many things for a quote that you may have heard already, that is cogito ergo sum, I think, therefore I am. René Descartes is a massive philosopher who has been very important for science and for all of us at that time, and he was one of the first people who created the dichotomy and the dualism between mind and body. I say one of the first, not the first, because in reality the first person to create this dualism between mind and body, or body and soul, was the philosopher Plato more than 2000 years ago in the ancient Greece. Then René Descartes got some of his concepts from him, and now in modern science is seen like the father of the mind and body dualism. What is the mind and body dualism? In reality, he added the third dualism, that is the mind, body and soul dualism, because the church at that time was not very happy with him talking just about mind and body. But the dualism theory hypothesis that pain or any injury was usually a mutually exclusive phenomena. If we talk about pain in the specific, for example, pain could be seen as a result of a physical injury or a psychological injury. The two types of injury at no point did not intertwine or interconnect, but they were seen as separate entities. According to Descartes, same stimuli produce same responses, so as we will see later, so you can start understanding that this model is not a precise model to describe the sufferings of the human being. Although, we have to say that for that time, for the 17th century, René Descartes was way ahead of his time. He was an innovator. So his work, what he did was great, but we've seen later, in the centuries later, that actually he lacked of something. So René Descartes was the father, what we can call, of the biomedical model of care, that has been the model of care that has been common and ongoing in the medical field, let's say until 1977, and we'll see why. Of course, it is not a clear cut, but we can tell that things from the biomedical model of care start changing roughly around 1977. The biomedical model of care wants the biology of the individual, the pathology, put at the center of the therapy. It's not the individual in his entirety, but is the disease, is the injury, is the problem. The biomedical model wants an organic explanation for all the symptoms. It doesn't matter the symptoms. If you have had an ankle sprain, it's because your tissues are sprained, are injured, therefore you have pain. If you have had low back pain for 30 years, it must be because there is something that is causing your pain, and once we've seen it and we fix it, it's okay. So, according to the biomedical model, tissue damage equals pain or pathology. So, if I have an herniated disc, or if I have osteoarthritis, or if I have fracture or a sprain in the ligaments, I must have pain. And if I have pain, I must have one of these tissue damage. So disease is seen as a deviation from the norm of measurable biological variables. So this diabetes and the experience of diabetes is when the sugar are higher of a certain level, or low back pain happens when there are certain changes within the body. So disease is seen like deviation from the norm. There is a model of normality, and wherever you go out from this so-called model of normality, you enter into the disease realm. So biomedical model of care leaves no room for social and psychological dimension of illness in its framework. The way the person processes phenomena is not important, and this is is a step back, because 2,500 years ago in Asia with Buddhism, and 2,300 years ago in the Western world with Stoic philosophy, was said that the problem is not the problem is how the person processes the problem. So how the person sees what is happening, how the person processes what is happening. That in the biomedical model of care is not taken into consideration, so nor is taken into consideration the social aspect of the person, the cultural aspect, the religious aspect, the social networks, and so on. Complex phenomena derive from a single primary principle. So, as I said before, if you have had the pain for 30 years, must be a cause for it. There must be an organic cause we can see, diagnose, detect, fix, and resolve. It is reductionist because all diseases must be conceptualized in terms of psychochemical principles, and is exclusionist because if you cannot describe a disease in such terms, it's not a disease. So, as you can understand already, mental illness are not seen as disease, because for the vast majority of them, they are not biological markers. So, just to give you an idea of why the biomedical model of care is defective, cannot be used as the sole model of care, we know that tissue damage does not equal pain. If you see this diagram, they took people without any symptoms of low back pain, so asymptomatic people. They did an MRI of their spine, and they find that 80% of people aged 50 had the so-called disc degeneration, and 69% of people aged 60 had disc bulge, and 40% of them had disc protrusion. So there are lots of people in which they don't have pain, but they have these degenerative findings, degenerative processes that we know that are not degenerative findings, but are just normal aging process of the body. As we age outside, we age inside, but that doesn't mean that there must be a correlation for the disease. Again, this study that is being conducted in 45 asymptomatic people, they did a 3 Tesla MRI of their hips, and they've seen that 73% of them, so more than 3/4 of them, they had the so-called hip abnormalities. In the 70% of the cases, that abnormality was labral tear, but we had contral defects, rim fracture, labral or paralabral cysts, and ligamentum teres. So people without any problem with the hip, 73% of them had what we call abnormalities. So again, if tissue damage equals pain, how do we explain that? Instead, we've seen, thanks God, with imaging and research, that a huge amount of what we call degenerative processes are present in all of us, but they are not cause of pain. Pain is a way more complex phenomena that is described by different aspects. So things start changing when, in 1977, we would say, if we want to put a clear cut, although already at the beginning of the 20th century, the American psychologist Carl Rogers, start talking about a patient, actually a person-centered approach, in which the person is put at the center of therapy. We are not putting the disease at the center of therapy, we are putting the person. But George Engel, an American psychiatrist, in 1977 came out with this paper, Biopsychosocial Model, a challenge for biomedicine. That is a paper that gathers some of the intervention he made at congresses over the years in that period. And he's a psychiatrist, so he brings two examples, the example of diabetes and the example of schizophrenia. And he says a biomedical model of care is not enough, is not adequate to look after people with diabetes and people with schizophrenia, nor it does describe the human experience of schizophrenia and diabetes. In the case of diabetes, in which we have clear biological markers, we can tell through the blood test or the lab results, we can say the sugar test, we can say yes, that person has diabetes, but that numbers do not describe the most important thing, that is the human experience of diabetes, that is how that person is living diabetes and how diabetes is impacting in the life of the person. That is fundamental if we want to offer a proper treatment to that person. Schizophrenia at the same time doesn't have clear biological markers, so biomedical model of care is not enough to explain and to help people suffering from schizophrenia, that is a devastating, terrible psychiatric illnesses. So George Engel, in that paper of 1977, he refers to himself like an heretic, someone that goes against the common vision of medical care, that is the disease at the center of the therapy, and he puts the person, he puts a new approach that is called the biopsychosocial model of care, in which we don't lose the benefit from the biomedical model of care. So looking at the injury, looking at the lab tests, looking at the biology is very important, but we want to integrate this with the psychological aspect, so how the person processes it, mood, emotion, so on, and the social aspect, that is the social network, the cultural aspect, the religious aspect, the money, and so on. Okay. So in this paper, 1977, he urges his colleagues to move from a biomedical model of care to a biopsychosocial model of care. I have to say that now, unfortunately, my belief is that things have not changed much. The difference is people talk a lot more of biopsychosocial model of care, but in reality, they don't really do it. There is always this putting the injury, putting the disease at the center, and I treat what I see. There is a lack of understanding, a lack of consideration, a lack of involvement of the psychological and the social aspect. So what we're going to do now, we're going to change a little bit the topic, and we're going to talk about pain seen through a biopsychosocial model of care. Before doing that, I would like to go with you through what is pain. This because the definition of pain of the International Association of Study of Pain that you can see in this slide has changed recently. Now I don't remember exactly when, a few weeks ago, after 40 plus years. So what is pain? It's described as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. That means that pain is a perception, is a sensory emotional experience that can be associated or not with tissue damage. You don't have to have tissue damage to have pain. They added 6 keynotes to help describing pain. Pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social aspect. What we were talking before is always a personal experience. It's a private, personal, subjective experience. So we cannot make the sin, commit the sin of trying to know better of the patient of how much pain they are in, because it's a personal, subjective experience. Pain and nociceptions are different phenomena. Pain cannot be inferred solely from an activity in sensory neurons. We know nociceptors are danger receptors, are receptors that sense signal of danger. They don't send signals of pain. So the activity of the nociceptors doesn't equal pain. Pain and nociceptions are two different things, and that is always good to be reminded. Through their life experiences, individuals learn the concept of pain. Again, is a very important and aspect. Pain is something that we learn. It could be say as a behavior that we learn over the years. So the more we are in pain, the more we learn about pain. And a person's report of an experience as pain should be respected. What we're saying in the point 1, I cannot tell to my patients, no, you're not experiencing this, no, you're lying. You cannot be in this much pain. We cannot say this pain cannot be explained, hence you are making it up. Every person's experience of pain must be respected. Although pain usually serves an adaptive role, it may have an adverse effects on function and social and psychological well-being. And the last important part is verbal description is only one of several behaviors to express pain. So even people that cannot talk, like newborn, very young kids, or adults, or elderly people with dementia, or anyone that cannot speak, it doesn't mean that he's not in pain. It's just that we cannot see as a verbal language as the only way to discuss and express pain. If you want to look at a more full definition and a definition of other aspects of pain, there is the link here in the slide that brings you to the website of the International Association of Study of Pain. So going back to the biopsychosocial model of care, we see how pain is influenced by the biological factors, psychological factors, and social factors. The 3 different aspects. Now, these 3 different aspects do not influence pain in the same way. It's not they contribute each to pain by 33,33%. But according to the case, according to the single case, we may have a biological aspect that is more relevant than the psychological and social one, or a social aspect that is more relevant than the psychological aspect and the biological aspect. So if I break my leg, I hope not, but if I break my leg tomorrow, well, in that case, the pain that I experience will be way more explained the biological aspect. So but in that case, the biological aspect will be more important and relevant, and it will need more attention than the social aspect. But if I have been having pain for 20 years, well, at that point, the biological aspect is still important, but much, much less than the psychological aspect and the social aspect. So these three domains are not the same, but they vary according to say, to period to period, person to person, and case to case. So, types of pain. We're going through a quick description of three different types of pain: nociceptive pain, neuropathic pain, and nociplastic pain. Nociceptive pain is pain that arises from actual or threatened damage to non-neural tissues and due to a high activation of the nociceptors. Neuropathic pain is pain caused by the nerve damage or by a lesion of the somatosensory nervous system. And the nociplastic pain is a very complex type of pain that arises from altered nociception despite no clear evidence of tissue damage. We'll see these three types of pain in the details now. So what is nociceptive pain? We made the example of spraining the ankle. That can be an example of a nociceptive pain. It is a pain that is clear, proportionate to the injury, and you can find mechanical features. So the person can tell you very clearly, I have pain when I do this, and I feel better when I do this. Okay, so there is a clear correlation. The person finds a logic behind the pain. So it is a pain that makes sense. Pain is associated with and in proportion to trauma or pathological process, and is usually localized in their dysfunction. So if I sprain my ankle, if my patient sprain their ankles, I would expect them to have pain in the ankle and not in the shoulder. Okay, it's usually intermittent and sharp, with, as we said, movement or mechanical provocation, clear, consistent, proportionate, and there is absent of expected proportion findings. Usually the person is not too scared of his pain because they see the logic behind it, they understanding, they can find a rationale behind it. This rationale starts lacking a little bit in neuropathic pain. That is a pain that we can observe, like for example in lumbar or cervical radiculopathy. The so-called, for example, as the lumbar radiculopathy is called sciatica. We can observe in people with diabetes. They have often neuropathic pain, or people who underwent cancer treatment, chemotherapy and radiotherapy can have neuropathic pain, or people who had tissue damage. For example, it's very common in some big gynae or colorectal surgery in which there is an impairment of the sciatic nerve. Is a pain that is described as intense, burning, shooting, sharp, or electric shock-like type of pain. The person, for example, can describe a sensation of pulling, or in the case, for example, or lumbar radicular pain, like someone who is biting their calf is another very common description. Pain is triggered by simple movements, prolonged position, sneezing, coughing, and is often worse at night. The pain comes along, not always, but often with pins and needles, lack of strength in the muscle, lack of reflexes, or anesthesia or reduced sensitivity. These are all common features of neuropathic pain. It's a pain that can be very intense, can be very, very challenging for the person. And then we have another very complex type of pain, that is nociplastic pain. Again, nociplastic pain is a definition that has been brought by the International Association of Study of Pain in 2017, and it refers to a pain that is out of proportion, unpredictable. It's a pain that makes no sense. The person and the therapist cannot find the logic behind it. It's a pain that persists even after tissues are healed, so usually we see it in people who have been struggling for a while. There is a strong association with psychosocial factors. The person has history of failed surgery, failed injection, failed assumption of non-sterile anti-inflammatory drugs, and and there is often high level of night pain and disturbed sleep and constant pain general. So pain that the person really don't understand, because they say, I have pain when I do something it shouldn't give me pain, and I don't have pain when I do something I think it should give me pain. So the people suffers because apart from the constant level of pain is that they don't find a reason behind it. They don't find the logic. Another way to divide pain, it could be into two macro categories, that is acute versus persistent pain. Acute pain, again, this is not a precise, clear-cut or precise definition, but we say is acute pain a pain that lasts within 0 to 12 weeks, 0 to 3 months, and persistent pain is the pain that lasts more than 3 months. Acute pain is the signal of something that is not working right. We know that there are some genetic conditions in which the person cannot feel pain, is unable to experience pain, and these conditions are not compatible with adult life, because the person dies before, because pain is there for a reason. It serves the purpose of protecting us. So we know not to put the hand into the fire, because otherwise we'll get burnt. So as we said, it's a signal. But in the case of persistent pain, pain is not a signal anymore. Pain becomes the problem itself. Pain becomes the illness itself. Pain becomes the thing that we have to treat. So in the acute type of pain, we treat what pain is bringing us to attention, is the medical condition. In persistent pain, we treat pain. And that is something that is very important to make us clients understand, because people that experience persistent pain, that have been in pain even for 20 years, they still believe somehow, sometimes, that the pain is there to tell them, listen, there is something you didn't check fully, there is something wrong that needs to be addressed, even if no one can find it. Instead, that is not the case. So, what happens with pain and why people suffer is because they get stuck into what is called a pain cycle. The pain cycle, a person starts experiencing pain for X amount of reason. As a result of his experiencing pain, the person will do an activity modification. So if you have pain, if you have low back pain, the first thing you will do, you will move less, you will do less sport, you will go less to the gym, you will walk less, you will sit less, you will do less of something in order to try to keep pain under control. These reduced activities over a certain period of time brings to loss of fitness, it brings to weak muscles, brings to overall sensation of stiffness. But pain comes often with sleep problem and tiredness, and we know that there is a mutual bidirectional relationship between pain and sleep issues. In this way, if you have pain, you cannot sleep well, because you turn around, you wake up, you struggle to fall asleep. But if you're already suffering from insomnia or lack of sleep, that we know that triggers and fuels pain. And if we have a lack of sleep, what will happen is that we are more vulnerable and susceptible to stress, fear, anxiety, negative emotion, anger, frustration. And that we know again as a bidirectional mutual relationship with pain. So the more stressed, the more fearful, the more anxious we are, the more in pain we are. And as the person starts getting medication, for example, neuropathic pain like gabapentin, Lyrica, we know that they come with side effects: foggy brain, a lack of memory, a lack of inability to focus properly. And that brings more frustration, sadness, stress. And as the pain persists and we are less and less active, we start putting on weight. That is even a way to cope with the situation. You know that people can eat a lot to try to cope with unpleasant thoughts and feelings, unpleasant situations. So we have weight gain. Weight gain leads to negative thinking about yourself and your image, depression, mood swings. As the pain persists, the person may be forced to take time off works, so have money worries, so we enter in the domains of the social aspect of pain. They may be forced to stop their relationship, to break their relationship, to change their relationship. And this cycle, as you can understand, is a cycle that is self-fueling. At that point, we don't need an injury anymore. What happened 10 years ago that caused the problem is not relevant anymore, because this cycle is self-maintaining. So the problem is not the problem itself anymore. The problem is the problem solving that the person in good faith put in place. So their way to try to solve the problem by avoiding pain, by doing things in order to avoid pain, is what keeps the pain going. The good news is that in order to break this cycle, it doesn't matter where you start. You can start by reviewing medication, if you are allowed, if you can, by introducing exercising, make it more active. You can start with sleep hygiene, you can start with emotion management. It doesn't matter where you start, as long as you break this cycle somewhere, you will provoke a shift to all the other domains. So you can start already giving some relief to the person. So there are different models to explain persistent pain, because still in 2020 we don't know very well why persistent pain persists, and what is the purpose of persistent pain, and why people keep experiencing pain for so long. There was the theory of central sensitization, and the model of central sensitization that is well accepted in science, although the problem with this model is that has been, I would say, abused, because now everyone that has had pain for a certain period of time that we cannot explain, we put them in the box of central sensitization. So we say that person is centrally sensitized. But that is not true. There are some people with persistent pain that feature central sensitization, some of them are not. So we need another model or a better model to try to explain persistent pain. Now, there is a model that is present in literature, and especially in the psychiatric literature, that is the model of predictive processing. It's not a model that in which there is much research about pain, but it seems like neuroscientists are going towards that direction to describe and to explain persistent pain. So there is not, as we talk, a huge amount of evidence for predictive processing and pain, but we reckon that over the next years there will be a lot more. So it's a very complex, very complex concept. Friston Karl, that is the English neuroscientist who wrote this paper, you can find in this slide, the free energy principle, has been accused of making this too complex even for other neuroscientists. So I will try to give you a quick overview of what predictive processing is and how we can explain chronic pain. So chronic pain is not an input-output process. It's not information that comes to the brain, that are processed to the brain and that gets out of the brain. So pain is not input-output. And the brain is not even a passive receiver of a flow of information. The brain is not sitting there inside your skull, between your ears, just waiting there, relaxed on the sofa, for information to arrive through the senses, to process them and to send them back. So what they've seen is that actually the brain is very proactive. The brain predicts constantly what is going to happen out there or inside us. So it keeps predicting reality. Okay? So according to internal model. So the brain, our nervous system, has an internal model, and it compare this internal model, this internal representation of the experience, with what comes up through the senses. If the internal model and what comes up from the senses, they match, so the brain reinforces the internal model as an accurate model. If they don't match, that is, happens what is called prediction error, and we'll see later the details what that means. This comparison happens most of the time at the subcortical level, so the person is not aware of this, and it's something that happens within milliseconds. So the subject is not really aware of what is going on. So we can say that the external reality exists in virtue of our internal one, and not vice versa. So it's the brain that predicts what is going on. So we perceive, we can sum it up saying that we perceive the brain's best guess of what is out there. Okay? So the take-home message from this slide is the brain is not a passive receiver of flow of information, but predicts this information in advance. So this is another very interesting paper from 2019 that you can find at the bottom of the slides. So if it happens that the nervous system has no previous exposure to the stimulus, it's something that happens for the first time, like I sprain my ankle for the first time, the sensory signals, the signals that comes from the senses, have a high precision relative to prior hypotheses made by the brain, and therefore an higher impact on perception. And that's explained why new injury, new condition are very accurate in their perception, because it's something that is new. There is not a strong internal model that takes over. But for many chronic subjective symptoms of any kind, I'm not talking only about pain, the perception of symptoms shifts in the direction of the hypothesis generated by the brain, which explain the low correlation that we find between objective pathophysiology and subjective experience. Do you remember when we said nociplastic pain is a pain that makes no sense, that the person has pain even when they shouldn't? Even simple movements like last time a patient with low back pain told me, I have pain even when I reach out to get the remote from the sofa. That is because one of the reasons is the internal model that our nervous system has, the internal model of pain, is so strong that what comes up to the senses, if it's not strong enough, it will be taken over by the internal model of the nervous system. So the brain proposes what it knows already. Okay, so the perception of pain that we have is not accurate at all. Even something that shouldn't give us pain is cause of major pain. Anxiety, theory, threat perception, and catastrophizing emotional states that often accompany these cases have the effect of worsening symptoms by maintaining vigilance to predictive pain. So, again, take-home message from this slide is the brain, the nervous system is an internal model. It gets compared to the information that comes through the senses. If the internal model is very strong, has been there for a long time, and the information from the senses are not strong enough, the internal model of representation will be the one that is gets proposed. If instead is a new injury, for example, a new ankle sprain, a new episode of low back pain, the information that comes through the senses will have a higher precision because the brain has not a strong internal model of representation. So how do we translate this to the practice? How do we translate this to the clinical practice of us physiotherapists? How do we challenge our mind prediction of pains through what is called expectancy violations? So we violate the person expectations of pain. So someone with low back pain, for example, is very common that has an expectation that lifting a weight up or twisting or pushing or bending their back will end up in pain. What we do to rewrite this internal model of representation to propose a new, healthier one, what we do is we have to challenge this expectation by asking the person in a safe environment, guided by a therapist, to do that movement that the person, or do that activity that the person thinks are going to be painful, in a way that don't trigger too much pain. And this, over a certain period of time, this exposure over a certain period of time, if done well, rewrite the internal model. So Lorimer Moseley said, bioplasticity got you into this mess, bioplasticity can get you out again. We could say that predictive processing got you into this mess, and predictive processing can get you out again. So here we go to the high importance of exposure therapy to challenge patient expectations. Exposure therapy is not something, it's not an exposure to load only. It's not that we have to expose a patient's tissues to an higher load only, but we expose the person to a higher level of anxiety, to fears, to unpleasant thoughts, to unpleasant feelings. We expose the person to being uncomfortable. Okay, so exposure is not really about, it's about conditioning the tissues, but it's much more. It's about making the person comfortable with being uncomfortable. In this way, we can rewrite a better internal model of representation. You can understand that passive intervention such as electrotherapy, ultrasound, but even manual therapy are not very useful if we want to challenge patients' expectations. Yes, manual therapy may be of some help to create a violence expectations, but it's really through exercise, and I would say through painful exercise, that done in a healthy way, in a protected and guided way, that we can rewrite these patients' expectations. So I think that every person with persistent pain should be exposed to painful exercises, of course done in a certain way and following certain guidelines. Such an exercise program, and a program in which we encourage the person to expose to fear, pain, anxiety, unpleasant feelings in all sorts of different scenarios and in all sorts of different ways, facilitate the reconceptualization of pain by addressing fear avoidance and catastrophizing belief within a framework of hurt not equaling harm. Okay, so the more we expose, the bigger is the variety of exposure. The more we expose the person to a certain feeling, the more accurate, the better is going to be the therapy. Okay, so this is was just a very quick overview that has the aim to leave you with some take-home messages. The first one is, please let's remember to put our patients at the center of therapy. They know better than us. They are the expert of their own condition, and we know that if we